Thank you so much to those of you who have joined us today. I'm glad you could make it. My name is Haven Spanier, and I'm the Senior Director of Programming at the University of South Carolina Alumni Association. And I have the pleasure of introducing today's host for you all today. But just a few housekeeping items before we begin. I want to give a huge thank you to Prisma Health for making this event possible today. And if you all have any questions during today's event, we would strongly encourage that all throughout the presentation as well as after. So if you have those questions, you can type them into the chat feature. If you aren't super familiar with Zoom, there should be a panel across the bottom of your screen with a chat button. If you click on that, you should be able to type your questions for Dr. Bennett into that chat box. But without further ado, I'd like to introduce our host today. Dr. Bennett is a professor of family and preventive medicine in the University of South Carolina School of Medicine in Columbia, South Carolina. He serves as the director of the Research Center for Transforming Health and director of the South Carolina Center for Rural and Primary Care. He also serves on the National Rural Health Association's Board of Trustees as chair of their Rural Health Policy Congress. I know we're all very excited to hear from Dr. Bennett today, so thank you so much for joining us.
Sure thing. Glad to be here. Sharing my slides now, so hopefully you should be seeing that. Everybody see those and hear me okay?
Looks good.
All right. So me trying to pull up the chat box here. All right, I think we're good to go there. All right, so what I wanted to do today was give you an overview of rural healthcare here in South Carolina specifically, and talk a little bit about what we as a center are trying to do to help it out and fix some of these gaps. There we go. My chat box disappeared on me. So, and like she said, please use the chat box to enter in questions. I'm going to try to keep an eye on it there. As we go along, I think it makes a lot of sense for me to answer questions as we go. Don't worry about trying to interrupt me or anything. You're not verbal, so I'll try to keep an eye on that and try to answer as we go. I'm going to see one question already that I will get to at some point during the conversation, but if I miss that, please pipe back in. So wanted to give a quick overview of who I am and where I came from. I actually grew up in Virginia and came to Columbia in 2001 to complete my doctoral work. I graduated from the School of Public Health in 2005 with a Ph.D. in public health administration, health services research. I've been with the School of Medicine, the UofSC School of Medicine, since 2005 as a professor in family medicine. And I've recently become, over the past year, director of two centers. One is the Research Center for Transforming Health, which is a research infrastructure center within the School of Medicine. And the other is the Center for Rural and Primary Healthcare, which you're going to hear a lot about us today. And like she said, I do work a lot with the National Rural Health Association at the national level on policy and various things as well. So in other words, I've been doing this for increasingly a long time, and it's interesting to think about that sometimes. So what is rural anyway? I think, you know, one of my favorite things to do is to ask people how they define rural, and the definitions are all over the place. And this does not change when you get into policy either. There's a link here. If you Google our website, there should be a link for the rural definition there. There's an infographic we did for the state that goes over the various definitions that affect our population, federal and whatnot. And based on the definition you use, we are either 9%, 18%, 34%, or somewhere in between rural. And if you see by the state map right there, there's only a handful of counties that are rural by all definitions. There's several that are only rural by two. And there's rural by 1, and it's just all over the place, which is just not very helpful, honestly. So there is a very useful tool. The Rural Health Information Hub has this tool called Am I Rural? And you can Google that. There's a link there at the bottom for you to reference there. If you go there, you can actually type in an address and it'll tell you how rural you are based on these various definitions. A lot of folks use this to gauge their policy, gauge, if they want to start a rural health clinic, would they be eligible? Are they eligible for Health Service Corps funding, things like that? And it is actually really interesting. I didn't do it this time, but I've done this in the past where I've had participants actually answer a poll. Are you from a rural area? And then they go and check and then see if it matches up. And honestly, the match is not that great because a lot of people perceive themselves as being in a rural area, probably appropriately, but some of the definitions just don't get there. So I grew up in a small town in Virginia, not a large county. It was close to Virginia Tech, but not in Blacksburg. My high school had 600-700 people total. And, I would call that rural. But if you go to the Am I Rural for my location where I grew up, by no definition is it considered rural. In fact, it's considered urban. And, there was a long time growing up, we didn't even have a shopping mall, just to put those into perspectives. We didn't have a Target when I was growing up. Things have changed a little bit since then, but bottom line is that it doesn't always match. The data doesn't always match. The classification doesn't match with what we perceive and what we see. Here's a good map that I like this map a lot better. This is for our state, obviously, and this is a census definition. They have urban areas and urban clusters. Basically, urban areas are anything greater than 50,000 people or a core area with a certain amount of people in it. So it's population density at the census tract level. The blue areas are urban clusters, and these are areas that are 2,500 to 50,000 people urban core. Higher population, maybe it's a large town, things like that. Anything that's not red or blue by the census definition is not urban and is therefore rural. And if you look at this, you're like, yeah, that makes a lot more sense. You can see the city centers, Columbia, Aiken, Charleston, etc. Florence is on there. And then you see some of your smaller towns in there. You've got a Camden, you've got a Winnsboro. And it makes some sense. The problem is a lot of places don't use this by itself because it's census tract. It's not zip code based. A lot of things are county based. And it just is difficult to put this into action. If you overlay this with one of the most common federal definitions, the OMB definition, which don't even go down the rabbit hole of the categories and acronyms. But everything in red, according to one of the most common federal definitions, is considered metropolitan, okay, urban. And you can see there's a lot of counties in there with just one little blue spot. That's an urban cluster by the census, but it's considered an urban county, largely because a lot of folks that live there commute to an urban area. They'll commute to a Columbia, they'll commute to Rock Hill, they'll commute to Greenville for work. So they consider that an urban area, part of that urban catchment area, and therefore not eligible for certain things. And I think if you've been to any of these areas that are in these reddish pink places that don't have a large splotch in the middle of it, you would probably argue these are pretty rural places. I really like this. Of course, I'm not in charge of anything at the policy level yet, and I don't know that I ever want to be, given everything they have to go through. But this is by zip code, and it is the percent of that zip code that is considered rural using the census definition. And it gets complicated, I know, but if you look at it, this kind of passes that face validity test. So the dark areas are those places that are really rural. The medium brown are mostly rural. Light brown is kind of rural, and the really light tan color is urban. And as you can see, it does make a lot of sense. It follows some interstates. It follows natural patterns of growth where you start with an urban core and you get further and further out. It becomes more and more rural, less and less urbanized. And to me, I like this because, like I said, it passes that face validity test. And one of my favorite examples with this is Winnsboro. If you've ever been to Winnsboro, you might be shocked to know that it's a urban area that is considered urban. But based on that definition I just used, it is 64% rural. And in my mind, that's pretty darn rural. And if you haven't been there, this is what Winnsboro looks like. Open spaces. The downtown area is very nice and cute, but it's economically depressed. The Walmart closed. It couldn't support the Walmart. It's just not it's not what you would think of as a thriving large urban area. And in case you're wondering, this is not unique to South Carolina. These are all pictures of urban areas across the US, largely because of that county problem, where if you look at the Grand Canyon of all places, it's actually considered urban. The Welcome Center is in an urban county because it is 4 hours away from Flagstaff, yet in the same county. So for all intents and purposes, you couldn't set up a rural health clinic there because it's not considered rural. So obviously there's problems here. And, I know this isn't helpful. It would be nice to be able to walk away from this and say, I know exactly what rural is in our state. I don't think we can do that yet. And you can always just say it depends on what you mean by it. It gets very complicated. One of my favorite definitions from a colleague of mine was, if you can go in your yard and use the bathroom without a neighbor seeing you, you're in a rural area. That's really difficult to implement policy-wise, and probably not something you should do regardless, but it gives you an idea of what people think of rural versus what rural actually is classified as. So let's pause for a break there. So let's just hold our nose, assert a rural definition. Don't worry about which one it is. I'm not going to bore you with that. But generally speaking, what does rural South Carolina look like? So it's slightly more female. It tends to be older in both directions. There's fewer children under 19, and there's a larger proportion over 65. It is more proportional non-white, particularly African American here in South Carolina. Growing Hispanic population. For a long time, Saluda County had the largest growth percentage in Hispanic population in the US. Fewer Asian Americans live in rural South Carolina. They tend to cluster in our urban areas. And more chronic conditions. So a larger proportion have diabetes or asthma, cardiovascular disease, mental health diagnoses. And more alarmingly, a higher proportion have 2 or 3 or more of these. So they're combined. They have diabetes and asthma and depression, for example, which makes their healthcare journey a lot more difficult. There's a lower percentage in the labor force, either by being less likely to be employed or higher unemployment. And there's more that are not in the labor force. They're either retired or students or stay-at-home parents. So there's a lower employment rate, which means lower incomes, lower tax revenues, all these things that can cause problems at the local level. They tend to have lower insurance coverage. And that kind of circles back to that labor force. Since so much of our insurance is tied to employment, there's fewer percentage that are employed. And so they have less likely to have insurance. And those that do have insurance, they're more likely to have public insurance, like a Medicare or Medicaid, than they are to have a private plan, like a Blue Cross or an Aetna or an Cigna. Those numbers are going to change. 2020 really did a number on employment and insurance coverage. Rural areas folks that do work, they tend to not work in larger companies that have stable employment and or insurance coverages. They work in tourism, they work in service industries, food industries, agriculture, recreation. those were all really decimated by the pandemic. And so a lot of folks will lost their job and lost their insurance because of that, we fear. So, we won't know for a little while what that impact is, but it's not going to be pretty, I think. So boiling down to health insurance and health care, there's a national problem in rural, not just South Carolina. So a lot of these things I'm talking about apply to just about every rural area in the state. We have huge disparities in provider access, HIPSAs, MUAs, and MOOPs. I'm sure most of you don't know what that is, but those are basically health professional shortage areas. There aren't enough providers there to serve the need for the folks. There's fewer physicians per 1,000, and so that is adjusted for the population. You would expect fewer physicians to be there because there's not as many people, but the per 1,000 is lower. Particularly when you're talking about primary care, PCPs, obstetrics, gynecology, pediatricians, there's a lot fewer of those folks, particularly in our rural areas. Our ancillary staff, all the folks that are around and contribute to that healthcare continuum, the care teams, RNs, LPNs, pharmacy, radiology, lab techs, all up and down the board, they are lower rates of employment in rural areas. Interestingly, licensed practical nurses do a wonderful job, but they have a lower skill set, they have a lower training threshold, and they have a lower scope of work. They're not able to do as much as an RN, but LPNs are almost twice as likely to be employed in a rural area than an RN is. So you have some differences, not only in just supply, but also skill levels and training levels as well. And especially for providers, physicians, those that do work in rural areas tend to be older. So they're closer to retirement. So we have a coming cliff of physicians that are going to retire that are going to be difficult to replace. We already have difficulty recruiting to rural areas. We'll hit on that in a little bit, but we're going to have some retirements, and this pandemic, I'm afraid, will kind of speed some of that up. We have some concerns about that. And finally, you have some issues on travel time. So it's not just, are they in your county? How far away from are they? But how long does it take for you to get to a provider? In South Carolina, it's a little bit easier where, we don't have a lot of the terrain or weather issues that they do out west, for example. We don't have blizzards. We don't have huge mountain ranges. We don't have to get on a ferry like in Alaska. But you still have to get in a car and drive. Rural areas don't have public transportation. Uber doesn't serve most of the time. Rural folks typically tend to live in households that are less likely to have a car. So you have to bum a ride from somebody or even pay for a taxi, which could be very expensive. So the travel time gets very complicated and very difficult. And we've done some modeling on this. These are primary care providers. So every yellow dot is a primary care provider in our state, according to licensure data. The green areas are all the places that are within a 30-minute drive to a primary care dot. You can see we're not completely covered. There's parts of our state that are more than 30 minutes away. And, if you look certain places, like if you look along the I-77 corridor, there are some areas that just have one primary care doc. And so you might be within a 30-minute drive, but it might be 6 weeks out before you can get an appointment because they're just overloaded and need help, but don't have any other help to get there. More alarmingly, this is the travel time map for obstetrics care in our state. So we have huge portions of our state that are not within 30 minutes of an OB. So if you're pregnant and if you're down there towards the South Carolina-Georgia border, for example, you might be driving 45 minutes just for an obstetrics checkup for your prenatal care. And that reduces the proportion of people who receive that care, that seek that care. Infant mortality is high in our state, particularly among women of color. These are all problems that can be attributable in some way, shape, or form to this problem. So we need to work on this as well. Moving on to facilities, there are a lot of rural counties that don't have a hospital, about 20%. Not every county in our state has a hospital. There are some counties that lost hospitals and have opened a freestanding emergency department, for example, but we still have travel time problems. Closures are a nationwide problem. There's a link here for it. We are pretty stable here in the state right now. We have several hospitals that are always on the edge of could close if a tragic event happens. Unfortunately, a tragic event happened all year last year, and a lot of these hospitals with razor thin margins are really hurting because of that. All the elective surgeries, non-emergent surgeries, the huge costs due to PPE, all these things put huge pressures on these hospitals that just are barely making it. So hopefully we can keep our rural hospitals stable in this state and keep them open. Also alarmingly, about more than half of hospitals don't have obstetrics care. Not every hospital in our state offers obstetric care. Only 30% of small rural hospitals across the country have obstetric services. So you're talking about, you might have an OB in your area, but you don't have a hospital that can deliver. So you're driving an hour, hour and a half to deliver. And if any of you have been in labor, I'm sure that that is not something you would want to do. Here's our travel time map for our hospitals in our state. The red dots are the hospitals, the green is 30-minute drive. And you can see there's large swaths that are more than 30 minutes away. Part of it, some of this with the lakes causing some natural barriers, some rivers causing some natural barriers if you have to go down to the bridge and come back around. But this is an issue, and you can see there's certain places where we need acute care of some sort. I don't know if it needs to be a hospital per se, but an acute care center, emergency care center, triage center care, obstetrics care center would be very, very helpful. And this is a project that is obviously very relevant right now. And these are all our pharmacies in the state. The different colors are just different classifications. And most of the state is covered within 30 minutes of a pharmacy. Even a CVS, Walmart, Publix, Kroger, all those pharmacies are in this data set. There are significant parts that are more than 30 minutes away. And as we talk about COVID, which we'll get to in a minute, as COVID rolls out, one of the modalities will be giving it to pharmacies to inoculate folks. We still have large portions of the state they're going to have to drive an hour, hour and a half round trip to get to their closest pharmacy, let alone a hospital or a clinic. So this is something that we're really aware of that could be a quality drop for getting these vaccines out to our rural areas. Couple things that have popped up, especially with the 2020 pandemic, was this really increased use of telehealth. A lot of people switched to telehealth. A lot of the regulations around it got loosened up to allow that to happen. And it seemed to work fairly well for a lot of people. One of the questions earlier was, how do we improve services to elderly folks not on the internet? Well, that's an extremely valid question. It's not a modality that a lot of our elders are used to using, may not even have that available to them. But all that being said, it is a useful modality for a lot of people. Right now, a lot of the use seems to be around mental health, which if you think about mental health services, this is a really good way to get some good quality mental health services in your home when you're comfortable, reduce that barrier to care. And there are many issues coming out of this pandemic. Hopefully we're coming out of it. It looks positive. Trends are trending positively. There's questions about telehealth. How can we use that going forward? There's a lot of issues around preventive services. A lot of children especially missed their shots last year. A lot of adults didn't get that mammogram, didn't get that colonoscopy. How do we catch up with that? COVID immunizations, we'll hit on that a little bit in a few minutes. I'm very concerned about provider staff burnout and turnover. A lot of our healthcare workers really worked extremely hard over this past year, saw a lot of morbidity, a lot of mortality, and that's a psychologically and physical toll. And there are reports of people leaving the healthcare field because of that, and it's understandable. So how do we prop that up in our rural areas, especially? One thing that is interesting is there's concerns that nursing homes might close, which would reduce an already low capacity in our rural areas. Frankly, the mortality rate was so high in a lot of these nursing homes that they don't have enough patients to fill their beds and stay open. And it's a double, triple, quadruple whammy of bad outcomes all around that would have been great to have avoided, but here we are. Um, how do we keep practices open is a big one. How do we contribute to the economic recovery of the community? These are all things that we need to figure out how to kind of help. And that's kind of where we are as a center. So what can we do about it? And that's a question we've been asking ourselves at the center about what's next for rural South Carolina, especially around healthcare. Whoa, what happened? Go back. All right. So who we are as a center, we are the South Carolina Center for Rural Primary Healthcare. We've been around since 2017, and it's funded through a legislative proviso. So we get funding from the state. The South Carolina Department of Health and Human Services is our contractor, so we report to them. And we manage a lot of money. The state has invested a good amount of money in this initiative to try to support, expand, fill in the gaps of rural healthcare delivery across the state. These are some of our basic, this is all wonky, our basic, we call them buckets colloquially in the office, where we try to do some clinical outreach, research, workforce, education support, and some innovative ideas as well. Here is our impact so far. You can see we kind of cluster in the middle of the state where we're located, largely because some of this is research, some of this are educational training programs at USC, but we've got dots all over the state where we're trying to either directly subsidize care. We've got training programs, we've got loan participants. We're starting to make really good strides as far as impact within the state is concerned. Just some examples of some of the things that we're funding and trying to help facilitate in the state. This is our clinical outreach program where we're funding, for example, pediatric subspecialties is a great example. We're sending pediatric cardiologists out to rural communities one day a month to see patients there instead of having the patients come to them. Working on getting neurology services out into Sumter. Supporting primary care, supporting dental care, which is a huge problem. Dental problems are one of the top 3 reasons for ER visits in this state. So funding that in rural areas is a huge impact. Behavioral health and primary care integrative services are a huge problem and something that we think will really address some of the needs. We have several initiatives around obstetrics, around training obstetricians, around training family medicine to be obstetricians, to deliver, not to be obstetricians, but to provide obstetric services. Working on a maternal fetal medicine project to improve just those maternal health outcomes and to get some of those travel times down. We have several what we call innovative programs, and these are community-based programs that come to us with a unique, innovative idea for funding. And this ranges from, we have a school-based behavioral intervention, which is really cool, getting behavioral health interventionists into school systems. Chesterfield's doing an employee wellness program. We have prison initiatives, prisoners that are emerging from prison, being released back to their communities. What's their healthcare needs like? How do we even know? So getting that kind of straight. College of Pharmacy, we've worked a lot with them on readiness, cancer screenings, all these kinds of things. That these are communities that have come to us with unique ideas that we funded and gotten going. One thing I'm really proud of that we're trying to do is we've taken a libraries and health approach. So Blue Cross Blue Shield Foundation, State Office of Rural Health, did a 1-year pilot of putting a social worker in a library, in a public library, and helping them connect community members to healthcare services, whatever that might entail. They came to us with an additional ask to continue the program. We took that and expanded it to 4 other sites, and you can see the sites there at the bottom that we're working on. And I know you're thinking Charleston County may not be rural per se, but the sites that they're working on, all of these rural folks come in and use those sites. And this uses a combination of community health workers, social workers, navigators to basically help connect those patients, those residents with whatever is needed. Signing them up through insurance on the marketplace, Medicaid eligibility, referring them to a provider, helping them to connect with a payment plan for a pharmacy. Whatever it might be, it's a trusted location people like their libraries, they trust their libraries, and now you have a trusted resource there that's not hired by health systems. They don't have these duplicitous incentives to really impact the health. So that just started this past fall. So we're very excited about that to see how that grows and impacts our communities. We do have a loan program in addition to other statewide programs. MDs, physician assistants, nurse practitioners can get part of their tuition paid if they work in rural South Carolina. We directly support some rural residencies. Winsboro, Sumter have family medicine and pharmacy residents out in these rural, not urban areas. If you're trained in a rural area, you're more likely to practice in a rural area. We have an infectious disease fellow. This group we work with infectious disease has a goal to eliminate hepatitis C from the state within the next 10 years, not just rurally, but across the whole state. And that's a really cool thing. Preventive medicine, we have preventive medicine residents interacting with rural communities to not only train there, but to do some projects and do some work with them as well. We do a lot of educational support where we're training our rural providers, for example, on ultrasound, microbial stewardship, not using as many antibiotics, for example. The College of Social Work is training MSW, Masters of Social Work students in rural settings. So they send them out to rural communities for their residency in their last semester of college to work. And then they kind of catch the bug. They're like, hey, working in a rural area is a really good thing. Training CHWs. And this kind of circles back to the question that was raised earlier about how do we serve our elders without technology? Well, I think community health workers might be a great way we can do that, because these are CHWs who theoretically should come from the community. They understand the community. They look and sound like the people in the community, and they're that conduit between the patient and the provider. So they go visit the patient at their home, look at what their impact, what their issues are. What do you not understand about your treatment plan? What issues are you having with your pharmacy, with your side effects? And they help bridge that gap. There are some places that will actually have that CHW that can facilitate a telehealth interaction. So they could pull up their phone or their iPad and have a consultation via telehealth that way. So there's ways we can bridge these gaps of, how do we get care to our rural places in a way that's acceptable and usable for them. And we do a good bit of research. This is kind of my passionate area. We've developed a lot of different things, a dashboard I'll talk about in a minute. We're trying to develop a better way to kind of figure out what is needed. So in the past, we've looked at need for physicians just as physicians per 1,000. Do they not have enough? Let's put some there. In my mind, we need to know that, but we also need to know what's the rate of diabetes. What's the percentage of women of childbearing age? What's the birth rate? What's the pregnancy rate? Because you might need more people in an area because there's more women who are pregnant or giving birth. Looking at pharmacy travel times, looking at these obstetric areas. And we have several contracts with providers around the state to do evaluations for them. This is our healthcare resource dashboard. We keep vacillating on the title. If anybody has a brainstorm on a great title, let me know. This is on our website, and you should be able to find it pretty easily. And what we tried to do with this, we're trying to serve up publicly available data to our communities. That first tab there, the county and zip code summary, it's got a wealth of knowledge on a county, but also all the zip codes within that county, on census data, on income, on ED utilization, percent with diabetes, food insecurity, basically any data point we could find at the county and zip code level, we've tried to include on here. And we've also made all these maps that are interactive. You can search, you can zoom in, you can click on the map, read the data from it. You can learn a lot about your area based on this. And I've worked with a lot of communities that wanted some data about their community, didn't know how to get it. We tried to help them. They just, they don't have the skill set, they don't have the training, and they don't have the time to learn how to pull data from the census. So we've tried to pull it all here in one place so people can go to one stop place and pull all the data from their communities that they are interested in. And like I said, that should be on our website. You should be able to find that there. Whoa, going back. And that's my quick snapshot, scattershot view of rural health in South Carolina and what the things that we're trying to do to solve that. Like I said, are partners with the state and the Department of Health and Human Services on those efforts. There's our website there, and there's our email. So please reach out to us via email if you have any questions about anything. There's a link for the dashboard. We do have a podcast, which I'm still kind of weirded out by. Hearing myself on a podcast is a strange experience, but we're trying to highlight all the good things that are happening in the state, not just healthcare wise, but arts, culture. We've had some really good guests on there talking about a wide range of things. We've got a podcast coming out about heritage foods, for example, community health workers, all sorts of different things. So you can subscribe there, and then you can follow us on Twitter and Facebook and things like that. So I will stop talking and let you all throw any questions my way. So is there work being done to reclassify rural? Yes and no. There's some federal moves to redefine some of the measures to kind of expand them to make them more, I guess, more face validity wise to do that. It's so overly complicated, and it depends on who the funding is from. If you're looking at healthcare, they use one definition. If you're getting a grant from the USDA, which funds a lot of rural type things, they have their own definition. The VA rural definition is different. So yeah, I mean, if I did nothing else over the next 20 years, if I was able to kind of redefine rural for the country, I could retire very happily, but I don't have a lot of hope for that. Yeah, so good question about preventive versus reactive care, I guess, is one thing you could say. There's debate on that, honestly. Generally speaking, there's a lot of good in prevention, okay? And if you talk about pure cost, it doesn't always pay off, quite frankly. But it depends on how you want to look at it. I mean, what's the cost of a human life, for example? If you give out flu vaccines, it may not save you money in healthcare outlays, but it does save you money in the sense of that person's not going to be sick and they're going to be productive and contribute to the productivity of the area. But also, that person doesn't pass away. And to me, that, there is a huge need to do the cost equation, certainly. But I think we as a country would be well served to move beyond that, to try to figure out how to pay for things, certainly, not pay for things that are wasteful or inefficient, certainly, but also to value the fact that having a healthy population is something we as a society should value more than just the cost of it. And for that to have a negative margin would be perfectly fine. That's my soapbox for that, but that's all right. So, and that's a really good question, Ariana, about what's the role of federal government in expanding healthcare versus public-private partnerships. Yes, and I mean, I think it's very difficult where we are right now, where a lot of our healthcare is delivered through for-profit or that requires you to be above margin, to have a positive margin to exist. And that's really, really difficult for rural areas where you don't have the supply, you don't have the demand, you don't have just the utilization to kind of offset that cost. In an urban area, you can build a hospital and you'll have enough patients through reimbursement to pay off that hospital. Well, in a rural area, you still need to build a hospital of sorts, not as big, but that's a sunk cost. That's a lot harder to pay off because you don't have as many people coming through. And there's a really good argument, Dr. Jan Probst has written about this, about trying to treat healthcare not as a service or even a commodity, but as more of a public utility. It's something that we as a society come together, we pay through taxes and point of care, and deliver this as a utility, as a service that's a good for everyone, and gets to everyone. There are ways you can utilize private entities to deliver a public good. It's certainly, a CVS, a Walgreens, a Walmart. You could set up clinics there. You could set up pharmacies there, and they could certainly do a lot of good there. But it's going to take some incentive / investment / subsidy from probably a government entity of some sort to keep that open and keep it going. They'll have revenues, but it probably wouldn't be enough to keep it going necessarily. So that has to be some sort of give and take there, if that makes sense. So how are we informing rural citizens? So we haven't been able to really leave the office or Columbia for the past year. So getting the word out has been difficult. A lot of these things we've developed over this past year. And we actually hired a faculty member whose full-time job, Dr. Weiss, her job is, she's our director of community engagement. And it's just that concept there of how do we get into our rural communities? How do we come up with solutions that are generated by them, supported by them, empower them to impact their healthcare delivery? Maybe we subsidize it for a while. Maybe we give them a push. Maybe we place a provider, any number of things, but we want it to be kind of driven community-wise. And so hopefully, we're hopeful by the end of the spring, maybe over the summer, vaccinations cases go down enough that we can start going back out into our communities, delivering this message, finding out what is needed by them, and then figuring out how to help them meet that need. So if any of you out there want us to come talk to your group, to your church, to your civic organization, whatever it might be, if you think you're in a rural area and you have questions, if you want us to talk about something, please reach out to me. We'd love to connect with communities at the grassroots, at the ground level, as much as we possibly can, because I think that's where change happens, and I think that's where it takes root and really grows into something very, very powerful. We're definitely also very cognizant of not being that academic partner, the ivory tower coming to a rural area and saying, this is what you need and we know better. We're trying to be aware of that and say, hey, we don't know what you need, but we've got resources. Tell us what you need and let us help you figure out how to get there. And so we try to take that approach as well. So please reach out to us if you want us to come talk to any of you all virtually right now or in person, hopefully later on this year. Yeah, so this is a good question about prevention, wellness, I guess you could say, health education, spreading that to rural areas. Absolutely. There are a lot of programs that do that kind of thing. We don't do that necessarily directly. Our group, we tend to focus more on the healthcare clinical delivery side of things. What you're essentially talking about is the public health side of things, exercise science, nutrition, wellness, those kinds of things. Those are all extremely valuable. My doctorate's in public health, so I'm a big proponent of that. And Dr. Weiss has worked with a lot of these groups in the past, and I think one of our goals for this year is to really connect with a lot of these groups that are doing this work in a real way, to not do what they do, but to supplement what they do. How do we take people, get them in an exercise program, and connect them with behavioral health, and connect them with the PCP, and get their medicine straight, or whatever the case may be, to come alongside and prop them up. But there's a lot of groups. I know our School of Public Health does a lot of work. There's nonprofits all across the state that do a lot of work. Healthy People, Healthy Carolina, for example. There's nutrition groups. Megan would probably, Dr. Weiss would throw something at me for not naming all the right ones, but she'd be the one that could chime in and tell me what they all are right off the top of my head. I don't have them off the top of my head. But there are certainly ones out there. There's several that are faith-based as well, talking about going to your churches, which I know are vital to a lot of our rural communities. I think it's called FAN. I could be wrong about that, but there is a robust church. Yeah, Faith and Nutrition. Great, thank you. Dr. Weiss is on board here. So there are these groups out there. If you know of others, please reach out to us and let us know. We'd love to cooperate with them. not necessarily do what they do, like I said, but if there's something else that they've identified as a need that we could help with, we'd love to be able to do that. Anything else? Yeah, and Dr. Weiss has some good things. Health People, Healthy Carolinas, Eat Smart, Move More, of course. Forgot about them. But yeah, there's a lot of great places out there.
Great. Well, if anyone has any last minute questions, go ahead and type those into the chat. But I want to thank you again, Dr. Bennett, for spending your afternoon with us, telling us all about rural healthcare. I know I certainly learned a lot. I'm sure everyone did as well. You all are doing great work to spread that across South Carolina and beyond. And thank you everyone today for joining us. We will be sending out a survey email so we can continue to improve our virtual events. And it will have the event recording as well if you want to go back to anything during today's presentation. And again, thank you to Prisma Health for making this event possible. But I'm glad all of you guys could join us today. And thank you again, Dr. Bennett.
My pleasure. Glad to be here.
Y'all have a good afternoon.
Bye now.